So ultrasound and adenomyosis. So adenomyosis is a relatively new concept in the field of transvaginal ultrasound. We, in the last few years, have become better at diagnosing it, and then we have moved on from the mere diagnosis to something a little bit more advanced. And why is it important to achieve the diagnosis? Well, the first thing is safety, because, of course, any uterine pathology can be something else. And if you are not confident about what you're looking at, you can make the wrong diagnostic decision, you can make the wrong treatment, and then you may put the patient in danger. And also effectiveness. If you want to know that the treatment you're suggesting is going to solve the problem, then you need to be right about the diagnosis you've made. And this is the two things that I'm really going to focus on. So I'm just going to talk to you about a case. This is a woman I saw 10 days ago. She came on a Wednesday morning. She's 41 years old. She's been trying for 2 years to fall pregnant. In England, we have the good or bad fortune of having sonographers, which are essentially people that have done a 3-year course in general ultrasound and then are let loose to do scans on everybody. And she had a scan by a sonographer in the community who was very worried that the woman was pregnant because there was a big cystic area in the myometrium and she didn't know exactly what it was. So they did a pregnancy test, they did a serum beta HCG, brought her back for another scan. She had another scan, and still they weren't quite certain what it was, and eventually she came to us. And this is the coronal plane of her uterus, and you can clearly see that there is a myometrial cyst just here. Or is this a pointer? Excellent. So here's a myometrial cyst, and you can see that the myometrial endometrial junction is disrupted, and there's this blebbing, this growth of the endometrium into the myometrium, and this is a case of adenomyosis. So this is my topic, how to diagnose adenomyosis. And there are 7 distinct diagnostic criteria on ultrasound that you can diagnose adenomyosis with. You can have asymmetrical thickening, not caused by the presence of fibroids. So you can have an anterior wall that's thickened, a posterior wall that's thickened, a uterus that just looks asymmetrical, and that is a diagnostic criterion. You get this parallel shadowing, and I'll show you individual examples of these as we go along. Presumably the presence of these glands in the myometrium give this effect of the rising sun if you have ever stayed up late in Greece to watch the sunrise out of the Aegean. So you see these rays just like you see in the sunrise on the sky. Then you get linear striations, and I'll show you an example of that. Essentially what this is strands of endometrium migrating into the myometrium, and that is visible on a high-quality transvaginal ultrasound. You get myometrial cysts, and these are essentially a collection of endometrium that is in the myometrium. Then next cycle comes along, this endometrium bleeds, the blood stays in the myometrium, gives you the impression of a cyst. And this can be, it varies according to time in the cycle, and I've seen myometrial cysts appear and disappear depending on where the woman is in her cycle. You get hyperechoic islands, which is the same thing. It's endometrium that's migrated into the myometrium. You can get distinct adenomyomas. This is a sort of a more focal pathology. The rest of the myometrium looks normal. And I showed you an example of an irregular endometrial myometrial junction through the migration of endometrium into the myometrium. Again, this is a woman who came to see us for fertility. She was one of the HCAs, one of the nurses that help us in theater, and she was 40 years old, and she had this uterus, and she wanted to get pregnant. And so we had a discussion about that. We did her ovarian reserve testing, which was poor because she had endometriosis alongside that. She had a uterus that was, as you can see, this is a transabdominal scan. It was reaching the umbilicus, and unfortunately, she had hysterectomy not long after the initial presentation. But clearly, this is an exaggerated example of asymmetrical thickening. This is the anterior myometrial wall. This is the endometrial cavity. This is the posterior wall. You can see that she's got really bad adenomyosis. The other thing that's interesting about this image is that it's always difficult with adenomyosis to see the boundary between endometrium and myometrium because obviously it's blurred through the migration of the endometrium. Then you get the parallel shadowing I talked about, these kind of appearances. Then you get the myometrial cysts here, here, there. You get hyperechoic islands, an irregular myometrial endometrial junction, and you can have an adenomyoma, which is essentially the same pathology, just focal. Let's see. So there's the uterus, that's the endometrium there. It looks normal posteriorly, normal anteriorly mostly, but there is a distinct area here, which is an adenomyoma. It's important to be able to make that distinction, because if you think this is a fibroid, then you book the woman for a transcervical resection, and you'll find something different, and you'll be in trouble. There will be no capsule, that this disease will be diffuse, and there'll be nothing to resect. And so you'll have some egg on your face trying to explain why you booked this hysteroscopy. So I said there are 7 different ways of diagnosing adenomyosis, 7 different criteria. Is there any value? Are they individually different? There is some work from Turkey to show that actually individual criteria are better or worse to make that diagnosis. But my main point today is that all adenomyosis is not equal, because obviously you can have one of these features and the woman has adenomyosis. You can have all 7 of those features and the woman has adenomyosis. Is that the same? Does it mean that they have the same pathology? So here is an example. We said asymmetrical thickening of the myometrium. There's one, there's another. This looks a little worse. There's a little stria here. There are cysts. And again, these are the stria we talked about. And then here's another one. See, the posterior myometrial wall is much bigger here, and there are cysts, and there are stria. And this is the initial picture we started from. So you can make a diagnosis of adenomyosis by seeing one of these individual ultrasonic criteria. But once you've made that diagnosis, you then you have to start thinking about whether this is a mild, a moderate, or a severe condition. And the evidence from this comes from a series of studies we've performed at UCLH over the last few years, my colleague Joel Naftalin and the team there. And we've shown that the more features of adenomyosis you accumulate when you do your scan, the worse the symptoms can be. So this woman has up to 8 features here. This is how heavy her period is. And this is an objective questionnaire about menstrual heaviness. Similar with pain. If you ask a woman to tell you, so score how bad her pain is at the time of period in a visual analog scale, 0 to 10, women that have more features of adenomyosis on scan have worse pain. And it turns out it's the same for success after IVF. In reproductive medicine, there have been studies that shown that adenomyosis makes no difference. Adenomyosis makes you more likely to miscarry. Adenomyosis is really bad for getting pregnant after IVF. And probably what's going on here is that we're using different diagnostic criteria. Different teams are saying, this is adenomyosis, this isn't adenomyosis, and therefore there is a difference in our outcomes. But if you then try and score adenomyosis and say, you've got 1, 2, 3, 4, 5, 6, all of them, the more features you accumulate, the less likely you are to be pregnant after a cycle of ovarian stimulation and embryo transfer. And to give you a kind of useful guide, if you've got 4 or more, then you have half the chance of being pregnant after IVF. What you do with that, nobody knows. There's, Professor Vlachos talked about prolonged downregulation. There is some evidence, for example, that prolonged downregulation reduces the inflammatory load in the uterus. Whether that actually makes a difference for getting pregnant, it's a question that remains unanswered. So there you go. This is how you diagnose adenomyosis, and this is how you then say this adenomyosis is okay, it's not that bad, or it's really, really bad. And there's correlation between what you see on scan and what actually the patient experiences. What are the differential diagnoses for adenomyosis? Well, there's 2. There's fibroids. And the difference between adenomyosis and fibroids is that one condition is diffuse, has no borders. Fibroids are pseudo-encapsulated tumors that have no central vascularity and have limits. So therefore, if you're faced with this dilemma, you can try and see whether the pathology you're seeing is focal, has a neat limit, more likely to be a fibroid, or whether it's diffuse, which is more likely to be adenomyosis. I hasten to add, it is not uncommon in a woman who's 40 to have both. She can have both fibroids and adenomyosis, and those conditions can coexist. Another useful trick to be able to differentiate between the two is to use your Doppler. The Doppler button will tell you whether there is circular blood flow around the lesion that you're examining or whether there are these kind of finger-like projections going through the lesion. And if you look at the histology of fibroids, they don't have central vascularity. Their vascularity is peripheral, so therefore, if there is central vascularity, it's less likely to be a fibroid, more likely to be adenomyosis. And the other differential diagnosis that, of course, we all need to be aware of, and thankfully is very rare, is a leiomyosarcoma, this kind of terrible picture where everything is distorted, there's no limits, no boundaries, and obviously you should be alarmed if you see something like that. Thankfully, it's rare, but it's not so rare in women having surgery. It's been reported between 0.23 to 1%. And back in the day when we had this worry about morcellating fibroids, there's a study from the States showing that in women operated for rapidly growing fibroids, the incidence of leiomyosarcoma is 1 in almost 400. So they are very difficult tumors to diagnose. But if you want some practical tips, in a retrospective study in our center at UCLH, looking at all the women that came through for a scan, and then we had the histological diagnosis, and I hasten to add we did no myomectomy for women with a leiomyosarcoma. Those that had sarcoma had bigger tumors. They were 10 centimeters or bigger. The largest lesion was bigger than 5 centimeters in the majority. By definition, a cancer does not respect tissue boundaries. So that's true in any occasion. If it's in the ovary, if it's in the uterus, wherever it is, it will distort the anatomy. The structure you are seeing is irregular because it's a cancer. And therefore, women that have leiomyosarcoma, it makes it much more difficult to identify the endometrial cavity because it's been disrupted. And there's this histological sign, and it's useful actually to look at the histological textbook when you do ultrasound to see what the histopathologists say about the pathology you're looking for. This coagulative tumor cell necrosis, which is pathognomonic of leiomyosarcoma, you can actually see that on scan. And here's an example, maybe not so clear here. I think this one is clearer. This is a situation where basically the middle of the tumor has started dying off and becomes soft. And this is what the pathologist called coagulative tumor cell necrosis. The thing that can confuse things, it can have cystic lacunae, like this, similar to adenomyosis, I guess, but it has irregular borders, like this, and like that. I'm not going to bore you with that. Good. So this is just a little message to take away. If you see something like this, cystic lacunae, irregular borders, central vascularity, large tumor, an older woman, of course you'll be alert to the idea that this might be a leiomyosarcoma. So to finish, adenomyosis is common. In a study that we did at UCLH, 20% of women presenting to gynecological clinic had some feature of adenomyosis. You can see it on ultrasound. The reliability of a scan diagnosis for adenomyosis is up to 85–90% on the latest reports. And the more features you see, the worse it is. And I'm going to leave you with a video because I like this one. So this is basically a woman who has a full panoply of gynecological disorders. She has a fibroid, she has adenomyosis, and then you'll see that she has a bladder nodule that comes from the adenomyosis. So as to whether you need an MRI, I think if you are an experienced scanner with a high-quality machine and you know what you're looking for, you can diagnose any endometriotic nodule quite reliably. Thank you very much.